the participant with us, Dr. Khalid Al-Tayyib, consultant neurologist, Leicester Hospital, Dr. Hosam Izzeldin, consultant neurologist, University Hospital, Southampton, and Dr. Saeed Ahmed, consultant nephrologist, and also Dr. Nimr Usman, consultant medical oncologist, Limerick University Hospital. Now the mic with you, Dr. Hosam, for starting.
Thank you very much, Dr. Shawgi. And just I would like also to welcome Dr. Shuaib Al Khalifa. He is a consultant immunologist in Salvador Hospital, who are kindly also joining us in the last minute to join the first talk and the first session. Thank you very much, Shawgi. And Hosam, go ahead.
Okay. بسم الله الرحمن الرحيم. رب اشرح لي صدري ويسر لي امري واحلل عقدة من لساني يفقهوا قولي. تحية لك دكتور عبد العظيم وللضيوف الكرام وللجمهور الكريم المتابعين اونلاين ابو صفحتك في الفيسبوك. My name is Hosam Ahmed. I'm one of the clinical fellows of Manchester Royal Infirmary Hospital, and today is my first participation in this very useful conference and meetings regarding COVID-19 and its implications and complications. So I'll be starting with the case presentation of a 55 years old man admitted with a 1 week history of fatigue and right-sided pleuritic chest pain with exertional dyspnea associated with fever, productive cough, and sore throat. So typical COVID symptoms. On background history of well-controlled hypertension and asthma. Can we go next? Next slide. So this is his regular medications. He's been taking amlodipine 5 mg for his hypertension and salbutamol and serotype inhalers for his asthma. So when he was presented initially, this is his vitals at his initial presentation. He was febrile, his temperature of 38.1, pulse of 99, and blood pressure of 410/70, a normal respiration, and good oxygen saturation on room air. SL1 score as 2. Next. So this is his initial examination findings. He was fully alert and oriented, but he was dehydrated with dry mucous membranes. Chest examination was clear, and cardiovascular was no findings on cardiovascular examination. So abdomen, CNS, cardiovasculars, no abnormality was detected on examination. Can you go next? So this is his initial bloods. White cells 3.7, mild leukopenia, and the lymphocytes was 1.15, which is normal. He's got elevated CRB 128, and this is his venous blood gas, mild alkalosis, and lactate was not significantly elevated too. And he's got some elements of rhabdomyolysis. He's got elevated CK. 879. So this is his renal function. So elevated urea and creatinine, eGFR 60, and his electrolytes were normal. And he had MSU sample was sent and came back as negative. And also he was swabbed at his initial presentation at ED. The swab was sent and came back, COVID swab I mean, it was sent and came back later as positive. Can we go next? So this is his initial chest X-ray. If you can take a look, there's mild haziness bilaterally, so it's indeterminate for COVID pneumonia. Showed mild changes. So he was initially treated with IV fluids and IV ceftriaxone, as were our hospital protocol. So if there's changes on X-ray, we treat as community-acquired pneumonia. So yeah. So surprisingly, 3 days later, this patient rapidly deteriorated and was scoring 4, and he was desaturated, and oxygen saturation was 89% on 50-liter oxygen, and developed type 1 respiratory failure. And CRB has significantly increased to 545, and he has got lymphopenia of lymphocyte count of 0.5, and he's got elevated LDH 3,189, and fibrinogen of 9, and mildly elevated ABTT 38.6. His troponin was negative, and initial ECG shows sinus tachycardia. Next, please. So this is his chest X-ray when he was deteriorated. If you can see here, there's extensive interstitial changes, shadowing bilaterally, extensive consolidations. Next, please. So transferred to the intensive unit and intubated, and 1 day later on intensive unit, he was started on continuous venous hemofiltration as his kidney function got worse. During ICU admission, he was found to have high inflammatory markers and a ferritin level of 22,137. Cytokine Storm was diagnosed, and patient was started on recovery trial as per our hospital, and he was started on anakinra, which is interleukin-1 receptor antagonist. Next, please. This is few days later, another chest X-ray. If you can see, there is a endotracheal tube and NG tube, and there is also PICC line on the left side, left neck side. So then he was extubated following 8 days ITU admission, successfully extubated. Next, please. This is another chest X-ray of the same patient. So it's improving. Around 10 days later on the ward, the patient has developed new neurological symptoms, including headache and short-term memory loss and lack of concentration. And neurological examination revealed abco-implanted reflex without any obvious neurological deficit. Next, please. So this is his initial CT scan because of the neurological symptoms. If you can see on the right side, there's right frontal hemorrhage with surrounding edema, but no obvious midline shift or signs suggestive increase in intracranial pressure. So and then we considered scanning, doing MRI scan to see whether there's any infection or ischemic behind this this bleeding, because sometimes the basic pathology is infection and then end with hemorrhagic transformation. But the MRI scan just confirmed the CT findings and ruled out any ischemic stroke or ischemic changes. So it's pure hemorrhage. Next, please. This is another view of the same patients, same MRI. If you can see the bleeding more obvious on the left side, and if you can see there is a hemorrhagic ring around the hemorrhage. This is indications that this is subacute rather than acute bleeding. I mean, it's suggestive that around 10 to 15 days, the age of bleeding. Next, please. So, right frontal lobe and anterior basal ganglia parenchymal hemorrhage on the MRI report. Also, the patient had MRA scan, magnetic resonance angiography. Also was performed and showed no aneurysmal changes or AV malformations. Then we did contact stroke team and rehabilitation. So, as we know, if you can go back to slide. So, as we know, COVID patients, there is few cases reported of COVID patients who developed neurological complications, and stroke, one of the complications of COVID. Both types of strokes, bleeding and hemorrhagic and ischemic stroke. So raising the questions, is that due to direct invasion of the brain because of the virus, or is that because of overwhelming inflammatory response? So, and this is an area of debate, and also whether this findings is coincidental because the patient is not to be hypertensive. However, it doesn't seem to be like that, because he's not he's young patient and he's not hypertensive for a long time. He's been hypertensive for like 3 years, and his history suggests is not revealing that his blood pressure is swinging during this period. So it seems that it was well controlled. So this is raising questions that is this findings is purely related to COVID, whether due to the virus itself or whether due to the inflammatory response causing the bleeding. Because there is some theory suggesting that the COVID virus might enter the brain through the either olfactory nerve or through the receptors. As we know, the coronavirus can use angiotensin converting enzyme 2 as a receptor, and this type of receptor is expressed in the brain in the serial cells. So, raising the question is this the possible physiology of complications of brain complications related to COVID, or is it directly? Is that is the virus getting into the brain through the olfactory nerve? Because there is studies in mice confirms that the virus enters the brain through the olfactory nerve, but it's not that's not yet confirmed in the humans. And in support of this study, many patients of COVID they developed anosmia, and which is sometimes or mostly it's reversible. And again, raising other questions whether this anosmia due to effect of the epithelial cells at the back of the nose that lining the olfactory nerve, or direct invasion of the olfactory nerve. So although it seems it's not directly related, it is not directly related to the invasion of the olfactory nerve, because most of the patients who got anosmia, it's reversible. So again, so it's mainly supportive to the theory that saying it's affected the epithelial cells rather than invasion of the olfactory nerve itself. So so this is a case of so this is another patient who is 81 years old lady who's been admitted with COVID and suddenly developed symptoms of confusion and headache and cerebellar symptoms in terms of dizziness, and on examination revealed right side steatokinesia and evidence of psalmoplegia. So this is her MRI scan. If you can take a look and guess what it shows. Can we go to next? So if your answer is brainstem encephalitis, you are correct. So there's some changes in the brainstem, in the midbrain and bones. There's some type of haziness suggesting a brainstem encephalitis, which is also one of the reported complications of COVID on the brain. So, and unfortunately, this patient was died of this complication, and she had a CSF showed normal cells, normal glucose, and normal CSF in general, apart from mildly elevated protein. And the CSF also was sent for another virus like herpes simplex, and it's negative. So CSF was absolutely normal for this lady, and her past medical history is nil apart from COPD. Again, raising other question whether this directly related to the nerve, to the virus, sorry, or whether it is other inflammatory response. Next. So healthcare providers should be aware that the patient with COVID-19 can present with encephalopathy in the acute setting and during hospitalization. And this is why we recommend an MRI scan if COVID patient develops symptoms of encephalopathy. Next. As I mentioned earlier, few cases with COVID-19 reported with neurological manifestations, and MRI brain should be considered in these patients to look for possibility of brain lesions. And neurology manifestations are more common in severe COVID-19 infections compared to non-severe ones. Sorry. Next, please. So here the list of the complications of coronavirus in the neurology system. So in general, we can divide it into two categories. Number one is para-infectious syndromes and post-infectious syndromes. So the para-infectious syndromes, including encephalopathy, so COVID patients, they might develop symptoms of encephalopathy even without encephalitis. And as we know, when people are sick and respiratory system is failing, that will have adverse effects on the brain. And because of poor oxygenation and some metabolic effects of the brain, this is this is another ways of brain complications in patients with severe respiratory compromise. And also central hypoventilation, one of the complications of COVID, and viral meningitis, so anosmia and ageusia, which is loss of taste sensation, which both are reversible. Sometimes can be irreversible, but most of the patients they have got sensation, taste sensation, and smell back. Encephalitis, few cases reported with encephalitis in China, in Wuhan, and in America as well. And stroke, whether it's hemorrhagic or ischemic. And acute necrotizing hemorrhagic encephalopathy, which is I think this is the most dangerous complication and fatal complications of coronavirus. There's one patient reported with this complication. And also myositis. So the virus can affect the peripheral nerves and can affect the muscles and give rise to high creatinine kinase. Next, please. So for post-infectious syndromes, this is like acute disseminated encephalomyelitis, Brainstem encephalitis, and transverse myelitis, Guillain Barré syndrome, and sensory neuropathy. There is a study, there's an interesting study was done in Wuhan, a retrospective study of 214 patients who developed neurological symptoms. And they divided the complications into the CNS manifestations and stroke, including stroke, and the peripheral neuropathy. So 5 patients of these 214 patients had stroke. 4 of them developed ischemic stroke, and 1 patient died of hemorrhagic stroke. Yeah. Next, please. So, so neurological manifestations are more common in severe infections compared to non-severe infections. And here we can see the risk factors for neurologic complications. And this is include advanced age, cardiac. As we know, this virus is known to cause myocarditis. So this is another risk factor of stroke. And respiratory disorders, whether it's that due to the metabolic effects of hypoxia in the brain and hypertension and diabetes. This is the most common comorbidities present in patients with more severe manifestations of infection. Next, please. As I mentioned earlier, can you go back, please? Yeah, angiotensin converting enzyme is the receptor of SARS-CoV-2. This is another study. The use of ACE inhibitors lead to increased expression of ACE2, making the cells more vulnerable to infection with the virus. Next, please. Yeah, the clinical studies are underway to test this hypothesis. And ACE2 can also be found in the glial cells, as I mentioned earlier, in the brain, and can be induced in neurons. So raising the possibility that stroke associated with COVID might be directly related to the infection. And I think this is a good area of further studies. Next, please. So, risks of COVID-19 for patients with neurologic diseases. So, I mean, what's going to happen to the patient who's already known to have a neurology problem and develop COVID? So, generally, patients with neurological conditions tend to be older than those without. So the risks associated with COVID-19 are of particular concern for neurologists who care for these patients. And I think we can get more information from the neurology consultants attending this meeting. So next, please. Yeah, this is another dilemma of we know that most of neurological conditions are treated with immunosuppressive medications. So, so immunosuppressive medication used in the treatment of neurological conditions. For instance, those who's been taking steroids. So, what's going to happen to these patients? So, it's yet unknown how much of an additional risk there is, both for infection and for developing a more severe disease course. Next, please. So, autopsy findings have not yet been clearly reported, and I think we need further studies about the affection of COVID on the brain cells. So coronaviruses, as we know, coronaviruses has been isolated from CSF and brain of patients, for example, with multiple sclerosis, and there's other coronaviruses being isolated, yes, from CSF. But what about COVID-19? So because we don't normally not yet we request COVID-19 CSF. Next, please. Yeah, this is the study was done in Oklahoma in America and released like 3 days ago. Of actually, this is the first autopsy findings released in English literature. So, of 2 patients died with COVID, but I don't think this is good examples to. I mean, to confirm or to rule out the direct effect of coronavirus on the brain, because it shows normal brain cells, and the patients who died of these conditions, as far as I know, none of them has developed neurological complications. So I don't think this is a good example for confirmations of direct effects of virus to the brain cells. So, so in terms of management, so there's no proven antiviral therapy for the human coronaviruses, and the main treatment is supportive, symptomatic. However, several drugs are being considered for clinical trials and empirical treatment of patients. So in our hospital, we use anakinra in Cytokine Storm, and we were initially trying hydroxychloroquine, but we no longer use hydroxychloroquine. So worldwide, there's multiple antiviruses being under trial, and we have got immunologists here that can explain more in this area. So yeah, supportive treatment in terms of oxygen supply, DVT prophylaxis, and treatment of secondary bacterial infection, and treatment of fever. If you have any questions.
Thank you very much, Hosam. This is a very fantastic talk. Now I think Ahmed Adlan, would you like to ask any question, or would you like to lead the debate?
Okay, I think there was just one question from the audience regarding the first case, the patient who had a background of hypertension and quite typical presentation for COVID, and then developed the cerebral hemorrhage. Was there any ECG abnormalities? Did the patient have an echo? Those are the main questions, really.
No, the ECG just showed sinus tachycardia, and probably due to his fever. Yeah.
And did the patient have a CT chest?
He had a CT chest on the CT chest, not CT brain. So no, he has no CT chest.
Okay.
Yeah.
Okay, so we can pass it on to the rest of the panel.
Dr. Sam, would you like to add any comment on this case?
Bismillah ar-Rahman ar-Rahim. Thank you very much, Hosam, for presenting, and thank you for the reception, nice reception and invitation. I think it's early days. It's very early days to conclude about what COVID can do for the central nervous system. My colleague Khalid is listening and he can comment after that. And even as a joke, really, I said to myself, working in these busy hospitals, how these people manage to find time to publish these lovely papers, which are coming throughout May, you know, as recent as 3 days ago, the last 2 weeks, last 4 weeks. So just to say, it is still early days in terms of knowing how far COVID can affect the central nervous system as well as peripheral. Now, referring to what Hosam has said in terms of the first patient, there is a possibility that this is just coincidental in terms of somebody developing frontal hematoma as a hemorrhagic stroke in the context of having COVID. Now, that is less likely. That's a possible thing, but it's less likely. The most likely scenario is that this patient developed the hemorrhagic stroke because he was in ICU. Now, any one of you who has been had the experience of working in the setting of ICU or with ill patient will know that people who go to intensive care, critical care, will develop a lot of complications. One of them, intracerebral involvement. And one of those can be cerebral hematoma, which could be small. So in this patient, very likely that the bleeding dyscrasias or the degree of rhabdomyolysis he had, evident by CK and the other hematological disturbances, wasn't significant enough to cause failure of the cerebral blood-brain barrier and cause a cerebral hematoma secondary to that. So we're still faced with the question of this patient still doesn't have enough vascular risk factors, did not develop pancytopenia enough to bleed in the brain, and so why he had it. So that brings a theory which Hosam has illustrated very nicely in terms of link with the angiotensin II receptors affecting the autoregulation of the brain. And I just want to add a couple of points which Khalid can comment on, which is the idea behind swinging blood pressure. So if angiotensin is being affected in the brain, you know, the blood-brain barrier is very robust and is very protective for the brain. However, if something like COVID has messed up the autoregulation, then you could be having blood pressure variable, which is swinging or labile, and that can rupture the vessels and lead to bleeding. And the role of the patient's age is that you have a pre-existing atherosclerosis and you have myeloid angiopathies and all these, which can lead to those vessels rupturing. That's why maybe younger patients do better when it comes to this. So just to highlight, definitely the COVID can go to the brain directly, can invade the brain, whether through the olfactory sheath, and there are autopsies, they found COVID in the brain. In terms of isolating it from CSF, not yet. So the summary is, COVID can go to the brain, okay. However, the most prominent theory behind the intracranial bleeding, possibly related to, if it is not severe, I'm talking about this patient. If it is not severe, it must be related to the autoregulation, something to do with failure of the angiotensin converting, causing autoregulation problem and then rupturing of vessels, plus or minus edema. And that would present, as Khalid would comment, would present mostly with encephalopathy rather than focal edema. So I think that's what I wanted to say. Definitely, Hosam mentioned about the overwhelming inflammation, especially if the patient is very ill. As this patient now recovered, moved to the ward, is still in hospital, that means the infection wasn't severe, as you could imagine. So the severity of the infection makes a lot of difference here. If it is very severe, causing disruption of the hematological factors, pushing a lot of inflammatory mediators to the brain, then that can cause too much damage, which could be global encephalitis or local vasculitic process. Leaving hemorrhagic strokes aside, COVID has been established as one of the observations we've seen in our unit in Southampton, that it causes straightforward ischemic strokes, just like through monoarthritis and large vessel or medium size vessel arthritis, like what we see in TB, tuberculosis, TB meningitis. Okay, so I think that's what I wanted to say. On the second patient, briefly, I think it's a matter of acute process. The only thing is the CSF being normal. Khalid might agree that make you feel a little bit skeptical about an infection that causes a lot of damage to the brainstem without the CSF being abnormal. So that makes me a little bit suspicious that maybe the changes on the brainstem might have been present before that. But thank you very much, Hosam. Congratulations, well done. Good presentation, and it's illustrated a very good point. And I will just conclude by saying to the panel and to the wider audience, I think COVID is sending a lot of lessons. In terms of neurology, as you know, all neurologists are very slow and take things easy. I think hold your horses and wait. Any virus that affects the human body or affect the brain can cause similar complications. We don't want to rush into causing COVID cause intracranial bleeding or COVID cause Becker stuff like encephalopathy or brainstem encephalopathy. I think any virus is capable of that, as you know. So maybe some of it because of just an infection, some of it because of it's a virus, some of it because it's a virus went to the brain, and some of it because the patient went to the ICU and spent time requiring intubation ventilation. If you bring 5, 6, 7 viruses, it will cause the same outcome. So I think it's still early days for this conclusion, but I think this is illustrate very, very well the need to keep looking. Thank you very much.
Thank you.
Thank you very much. Dr. Khalid Al-Tayyib, would you like to add any comment?
Thanks very much, Dr. Hosam, for this very nice presentation and for the interesting cases. And thanks for the highlights from Dr. Isameldin. To be honest with you, actually, we are in the early stages, and what I'm going to say is we have actually more questions than answers. Regarding this problem, it is a viral infection which can affect both central nervous system and the peripheral nervous system, and more cases actually are coming reported. This morning we are in a meeting, and one of my colleagues is a stroke neurologist. He mentioned that more cases coming regarding microbleeds in the brain. We don't know exactly the pathology, and my message to Dr. Isam, the definite answer, as you know, Dr. Isam, in neurology, brain neurology problem like this is autopsy, come from autopsy, and we don't have many autopsies from these cases. It's quite difficult, so I think we better first concentrate on a few things here in his 2 cases, and John speaking about neurology and the virus itself. As I said, we are expecting more cases, neurological cases, which could be very devastating, including Guillain Barré syndrome, to come up in the future with COVID-19 cases. Encephalitis and acute necrotizing encephalopathy Again, this is very devastating. ADEM, which is acute disseminated encephalomyelitis, a very devastating cases. We expect actually in the future to see many cases reported in the literature about these things. Regarding the pathologies, it's too early at the moment, especially about the bleeding. But we can have good explanation for the ischemic stroke here in these cases. Don't forget, it is a virus like other viruses which can cause vasculitis. It is known to cause myocarditis. This is another potential site for thrombus coming. All right. This can explain the ischemic stroke. But as you said regarding the hemorrhagic stroke or brain bleeding, we still don't have a definitive answer to this, why it's happening, whether, as you said, given that the patients are elderly patients, they have hypertension, they might have a myeloid angiopathy, and this needs to be explored in the future. All right. The patient has hypertension, this patient, for 3 years. We know hypertension could be maybe even longer than this before starting the treatment. My gut feeling with this MRI that this right frontal lobe hemorrhage, as Dr. Isameldin said, might be coincidental. But going back to the other case, which is clinically is definitely encephalopathy, we are seeing some changes actually in the brainstem, and putting things together. I'm not sure at which stage the CSF was done, but if you know, Dr. Isam, that even in HSV encephalitis, if you do the CSF early, the CSF will come back normal, even including the viral PCR. And the recommendation from the Liverpool ID guys is to repeat the CSF again, maybe in 48 to 72 hours. We do have a lot of experience with this in Nottingham, where I myself did repeat the CSF after 48, 72 hours. And the CSF was significant, even the viral PCR come back positive. So why not the same case in COVID-19, given this is a viral infection? The other thing is this patient actually, we couldn't find anything else to explain his encephalopathy, which is evident clinically, and even the presentation is of brainstem. So we can say that this could be a case here from the COVID-19. And the most important point here is if this is the case, and we are going to get another cases of brainstem encephalitis, then we have another problem here, because the patient presenting initially with respiratory symptoms, intubated, successfully extubated, and then go back to have a brainstem involvement, which we know is going to cause hypoventilation again. And there's a paper I saw it this morning is actually wondering whether some of the patients, even who were intubated early on, whether the hypoventilation is respiratory or it is related to the brainstem. The difficulty here, especially here in UK and other parts of the world, is now the MRI is not going to happen immediately with these patients who are COVID positive. A lot of precautions going on here. We experience this now every day in our wards, saying that the patient is highly risk, infectiously highly risk. We are not going to do an MRI. CT is very quick, 5 minutes, can be done easily. CT is just rubbish in brainstem, and you can get just a normal CT or unremarkable CT in a patient with brainstem encephalitis. So this is another difficulty here. Hosam is lucky actually to get MRI on these two cases. So this can be another problem in the future. And then, as I said, we are still early in the neurological cases report of COVID-19 positive patients, but I do expect to see patients with Guillain Barré syndrome. So it will be another catastrophe that the patient survive respiratory failure, go back home, 2-3 weeks later started to have ascending neuropathy, and then back again Guillain Barré, which is going to affect his respiratory muscles, and get back to the ITU again with respiratory failure and intubation. So it will be a big problem. And then back to the immunosuppressants and disease-modifying therapies. It is a big question about those who are on immunosuppressive therapy. The only thing coming through in the literature now, and NICE and NHS published recently, is regarding the MS patients. And quite interestingly, actually, most of the medicines we are using for the MS, including interferons, the recommendation is to carry on, continue, and there is no evidence that they're going to affect the COVID-19 patients. In fact, even some of these medicines which cause lymphocytopenia, like fingolimod, Izzeldin, or dimethyl fumarate, they didn't find significant worsening of COVID respiratory symptoms. And the recommendation is to continue giving these medications. Other things in immunosuppressants will be the myasthenia patients taking mycophenolate or azathioprine, or taking prednisolone, steroids. We don't have the data, and still the recommendation is the consultant physician looking after the patient should treat individually. So a lot of questions, few answers. Dr. Hosam, he gave a very good point about the pathology in the brain, about what's happening regarding the blood-brain barrier, regarding, because the patients are all patients, whether this is because of fragility or atherosclerosis of the vessels. I think these all are reasonable justification from Dr. Hosam, but the problem, as I said, is it is too early, and it's quite difficult to answer all these questions at the moment. But I do expect a lot of neurology problems related to COVID to come through in the near future. Thank you.
I have a question. Can I ask?
Thank you very much. Yes, Hind, you can ask, but I think we're a little bit running behind the time. If we can just make it in 1 minute before we pass it to the immunology and hematology team to start the second session. Yeah, go ahead, Hind.
My question about the lumbar puncture procedure on those patients. Do you deal with them like the normal, patient without COVID, particularly if they're confirmed, or even if they have clinical suspicion without like a confirmed test? So the procedure, what is the threshold for doing the lumbar puncture, and what precautions do you do it with? Just a surgical mask? What exactly the?
Well, if the patient is COVID positive, we take the full precautions. I do have one patient the week before last week was COVID positive. He went to ITU, he had the lumbar puncture, but was with full precautions. But if the patient is like having just fever symptoms and he's COVID negative, or still you don't have the result, you can just have the surgical mask and have the routine one which you do as usual.
Just to add, in terms of threshold, Khalid might agree that you should have very high threshold for doing CSF. As I said earlier, anybody with viral infection will have all the triage of all these symptoms. So you should have very high threshold in a way that you shouldn't be encouraged to do lumbar punctures more in COVID compared to others. Just have a low threshold, because some of the manifestations can be from general metabolic upset, some of it from the general sepsis, some of it from brain edema, encephalitis, encephalopathy, which is going to bound to recede, and it might not change the management. So if you have somebody with COVID and they have a little bit of CNS symptoms, and you did lumbar puncture or you didn't do lumbar puncture, the outcome is more or less a piece of information. How much the patient is going to benefit from it, we're not sure yet. Thank you.
All right, thank you very much.
Yes, I agree, Hosam, and we didn't have many patients who have lumbar puncture just because they have like headache, which can happen even without without other neurology symptoms. We didn't do so many lumbar punctures, and there isn't actually even the literature mention of so many lumbar punctures done in COVID patients just because they have one or two symptoms. And as you said, totally agree with you. Even if they have encephalopathy, it might be just metabolic encephalopathy. So the lumbar puncture is not going to make changes to the treatment.
So you depend on the imaging here, like MRI and CT more. Okay.
Yeah.
Thank you very much.
Half a minute. Just as Khalid said, I answered this for the wider audience, for the residents, for the SHOs, for the registrars, for attending. This is important because even covering medical wards, usually we get referrals as to CNS involvement or even medications, you know. So just to say that the brain can be affected by things other than infection. Could be inflammation, could be the general metabolic state, could be the general metabolites or the inflammatory markers. So have a high threshold for doing a lumbar puncture. Don't do it unless you think it's going to make a difference to the patient. This is for the wider audience, and I totally agree with Khalid. That's why he has seen tens of patients and he only done one lumbar puncture. That's reflect exactly what I was referring to. Thank you.
Okay, thank you very much.
It is a general concept, in neurology, it's like invasive procedures. If it's not going to make changes to the management, we don't do it. So even if it is not coronavirus. Yes. Thank you.
Okay, thank you very much. We'll bring that session to the close now. That was fantastic. Thank you to everyone who participated.